Hi, I'm Ariel Crook from Ball State Community College's Respiratory Care Program. I'm here today to demonstrate a rapid sequence intubation. This is my fellow classmate, Casey Pennick, and she will be my assistant today during the intubation. First of all, for any intubation, you're going to want to gather the appropriate tools and medication. In any intubation, you're going to use a sedative and a paralytic. The sedative we chose to use is propofol, also called Diprivan. You push 2 to 3 milligrams per kilogram. IV push provides a rapid onset and of brief duration. Cerebroprotective, which basically means it lowers intracranial pressure. It has anesthesia properties, is extremely potent. It causes cardiovascular depression and hypotension. Respiratory depression is dose dependent. The paralytic is rocuronium or zimmeronium, 0.6 to 1 milligram per kilogram IV push in less than a minute. Duration of action is 30 to 60 minutes. It is non-polarizing NMBA. It has minimal effects on hemodynamics and a low incidence of histamine release. You're also going to want to make sure that you just have the appropriate tools for intubation. Obviously, you're going to need an endotracheal tube, and you will base the size of the tube on the patient's age and size. Today we have chosen a size 7.5 for a small adult. The common weight is, or age and weight is from 9 years old to an adult, and also a weight of 85 to 130 pounds. There's a stylet inserted. This is just to make the endotracheal tube more rigid. And also, you're going to want to go ahead and curve it like a hockey stick, and this just allows easier access into the glottic opening. We also have a 10 ml syringe, which will be used to insert air into and out of the cuff. You're going to insert the air, it's going to inflate the cuff, squeeze the cuff through the packing to be sure not to get any germs on it. Make sure that there's no tears or rips. The integrity of the cuff is fine. Make sure you deflate the cuff completely. I'm just going to double check to make sure. All right. You're going to want to have a Mac or Miller blade, size 3 or 4, and a handle. You want to put them together and make sure that the light on the endotracheal tube blade is working appropriately, which it is. And you're also going to have a colorimetric analyzer, and this is used to make sure that you have proper placement of the endotracheal tube into the trachea and not the esophagus. It will change from purple to yellow if it is in the trachea. You're going to want to make sure that the patient is completely stable before any intubation. Of course, that's going to be more reasonable in an elective intubation, but you want them to be as stable as possible in any intubation. You're going to have a bag valve mask connected to 100% oxygen, and you will have this turned on to flush. I'm not going to have it on flush just for this video, simply because of the noise it makes. I'm afraid you'll be hard to hear me, but I will show you what it will look and sound like on flush. You want to make sure that the patient is in the sniffing position, which they are. You're going to want to hyperoxygenate and hyperinflate for a minute. This is just to get their oxygenation status elevated. It gives you a little bit of cushion during the intubation procedure because you don't want their PaO2 to drop too significantly if it can be helped. You're going to want to try each intubation attempt within a 30-second time interval. If you cannot get it intubated within the 30-second time interval, you're going to remove the tube and hyperventilate and oxygenate for another minute before another attempt is tried. Okay, the patient has been hyperinflated for a minute. You will take the blade in your left hand, insert it into the left side, sweep across, pulling the tongue, pull at a 45-degree angle. Visualize the cords, too, please. Try not to take your eyes off the glottic opening. the tube. Remove the blade. You want to make sure that you never use the teeth as a fulcrum because it can cause some serious damage. Got the analyzer on. Alright, it is obvious that we have a little bit of a right main stem bronchus innovation. So what I will do is I will reconnect the syringe, take out some of the pressure and remove it just slightly. Okay. Now we have equal rise and fall of the chest. What we would do is I would secure the tube while I let my assistant listen to the lung fields. You want to hear lung sounds in every single field, and you will also have a nurse listen to the stomach to make sure that there isn't any air going down into the stomach.
Good balance or reference.
Alright, we would secure the tube either using tape or a tube holder, and we would connect the patient to mechanical ventilation. Thank you.